I should pay you extra for that. That is beautiful music. Thank you. Good afternoon, everybody. Like I said, I'm Brian Davis, and I work at the Greenville Health System, and I, along with colleagues of mine, David Suddeth, Cody Reynolds, and Dr. Patrick Springhart, who you'll hear from in a minute, I work with our Office of Innovation, and so what we do is work on commercialization throughout the continuum of the innovation spectrum. So it's my honor to be able to introduce the panel to all of y'all today that you're going to be hearing from next. And I also have the honor, before I say that, I have the honor of serving on SCbio as a board member and as an executive committee member, and it's been really exciting to see what Sam's done with this great organization and to see all of you here in the audience that make everything we're talking about possible and all our aspirations that we're shooting for possible. So thank you all for that. One thing that has kind of struck my mind as I've kind of sat back and been listening to some of the stuff that's going on today and some of the conversations people are having is that I think the currency in our state is really relationships and it's collaboration. I feel everybody's friendly that's sitting up here on stage and everybody wants to make things change. So I look forward to seeing those connections happen in our office and what we're doing. We are wide open to partnerships with industry, and a big part of what we do hinges on relationships and collaboration and leveraging resources we have to partner with early stage companies. But I'll shut up before I talk too much about myself and what we're doing. That gets me really excited. So our next panel represents some of the finest minds in South Carolina. These are some leaders that serve some incredible roles in their organizations across our state, and they wake up every day and have to deal with the ever-changing dynamic nature of healthcare and how to provide innovation and provide the next level of care for our patients in the future. What they represent as well is kind of a good cross-section of what it takes to push that forward, where you need your administrators, you need your policy directors, you need your clinicians, your nurses, and everyone to be able to work together to make this stuff happen. And so what I would tell you is that I think we're going to hear a pretty cool story from them about what that looks like and what the collaboration looks like in our state and some of the what they're leading. So with that, I'm going to start calling you guys to the stage and introducing you. First is going to be Mr. Thornton Kirby. And Thornton, y'all can just come on up as I call you and have a seat. Thornton currently serves as the CEO of our state's hospital association. And he's going to be kicking us off kind of as our moderator, but also as kind of a unique story, walking us through healthcare policy and kind of how we got to now. Yes, and you all get your own song, so yeah. Yeah. And I'll finish introducing the rest of y'all, but this is beautiful. I can do it to theme music. This is good. So the other folks, individuals you see coming up, we have Mr. John Singerling, who is a good friend of ours at Palmetto, that you'll be hearing more about him with Prisma and some other things. He's the president of Palmetto Health System. We have Dr. Patrick Crawley, he's the CEO of Medical University of South Carolina. And then we have Dr. Springhart, who I have the pleasure of working with at GHS. He's our VP of Innovation, and we get to play in the sandbox together a lot. So with that, Thornton, I'm going to kick it off to you and let you take us through.
Thank you, Brian. You guys, why don't you join me sitting down on the stage? It's a pleasure for us to be here, and I'll tell you one quick story. I know we're a little bit behind schedule, so we're going to make sure we finish on time. When I worked in Washington in college for Senator Strom Thurmond, I learned an important lesson about finishing on time. You know, when the Congress or the Senate changes party control, all the chairmanships have to change. And Strom Thurmond had to give up his chairmanship to his arch rival Ted Kennedy one year, and it really bothered him a lot. And Kennedy made a long-winded speech about how much he was going to do and how much he'd already done. And in the middle of his speech, Senator Thurmond leaned up to the microphone and said, "Excuse me, Senator, the roses you ordered for yourself have arrived." So I learned then people will cut you off if you go too long. So we're not going to abuse your time that way. What I'd like to ask these gentlemen to do is to introduce themselves briefly, and I'm going to start with Dr. Patrick Springhill. Patrick, thanks.
My name is Patrick Springhart. I'm a urologist by training. I work at the Greenville Health System, and I currently serve our system as the Vice President of Institutional Innovation.
Hello, I'm Dr. Pat Cawley. I'm the CEO of MUSC Health. That's the clinical enterprise of the Medical University of South Carolina. You're going to meet our president here in the next session. My role is to oversee the part that sees patients And because we're a deep part of the Medical University of South Carolina, innovation and how we get things into the clinical enterprise quickly is a deep part of who we are.
Good afternoon. My name is John Singerling. I'm in my 23rd year at Palmetto Health. And January 1, we'll change our name to Prisma Health in the Midlands affiliate. And I'm proud to be here today. Thank you.
Thanks, John. And I'm Thornton Kirby. I'm the president and CEO of the Hospital Association. The Hospital Association was founded in the state nearly 100 years ago to be an advocacy organization. In the last decade or so, because of the leadership of our hospitals, several of whom are represented here, we have become more of a quality improvement and performance improvement organization. And we may have time to talk about that later. But what I wanted to do to set up the conversation today, in a conversation with Sam preparing for this, I thought it might be useful if we're going to talk about the future of healthcare delivery, just to remind ourselves how we got to this point. So if you'll indulge me, I'm going to give you a couple of slides to tell you how we got here. So in the United States, our healthcare system that we have today did not exist prior to the Second World War. We had a global depression. We did not have any money really to spend on healthcare, but even if we had the money to spend on healthcare, we didn't have anything much to spend it on. This is a picture of bread lines in major U.S. cities. We just didn't have the wealth at an individual level to spend it on healthcare. But we didn't discover even penicillin until the late 1920s, and so it wasn't even, we didn't enjoy the technological advances in pharmacology and medical devices that we do today. So we get up to the Second World War, and we sent 5 million men overseas to fight in a war. At the same time, we had to produce a lot of wartime munitions, guns, ships, planes, tanks, jeeps, everything you could think of. And we opened factories for those purposes. Well, we didn't have enough workers. We were 5 million men short in the labor supply. So we did several things. One was we brought women into the workforce. You all remember Rosie the Riveter. Women were an indispensable part of our workforce in the war effort. But we also imposed price controls, and we imposed, very importantly for our conversation, wage controls. The federal government began to see upward pressure on wages because in a labor shortage, employers began to compete. We've been talking about this all day. How do you compete for talent? Employers began to offer more wages. The federal government did not want to see runaway inflation in wartime, and so the federal government imposed wage controls. Nobody gets a raise until the federal government says so. That's pretty draconian. So what did employers do? Well, they got creative. They offered more benefits than they had in the past. And the one that was introduced and popularized in the Second World War was employer-sponsored health care. That's where we get the American model of employer-sponsored health care right out of the Second World War. So we did that, and a lot of people were covered by the employer-sponsored health insurance, and we came back. The war was over. Our economy was booming, and we just kept right on with that model. Now, fast forward 20 years, we realize there are some people who are never going to be covered by insurance in an employer-sponsored model because they don't do what? They don't work. And if you're not working and no one in your family is working, then you aren't covered. So we adopted 2 programs to cover the elderly, that's Medicare, and to cover women, children, and disabled persons, and that's, generally speaking, that's Medicaid. Now, one other funny Strom story, when I worked for Senator Thurmond, he kept confusing the two. He'd say, now, Medicare, is that for the old people or the poor people? And we used to have to tell him, Senator, you're on Medicare. It's the older people. But that's what we did. After 20 years of trying an employer-based model, we adopted these 2 government programs to cover the elderly, the poor, women, and children. And those are Medicare and Medicaid. We still have them today. We ran another 20 years down the timeline, and we realized there are still people who do not have insurance because they don't qualify. They're not eligible for those programs. And one of the biggest reasons for that is the fact that in the 1960s, when we adopted Medicare and Medicaid, we still had a draft. And all able-bodied men in this country were required to serve, and they got VA benefits for life. We didn't have a problem of uninsured men in the 1960s. By the 80s, no longer a draft, we had a lot of uninsured adults. So Ronald Reagan, working with Congress, signed a law that is known in the healthcare circles as EMTALA, the Emergency Medical Treatment and Labor Act, that says every American, every person can go to an emergency room and has the right to be screened and stabilized even if they can't pay. So that was the next overlay 20 years after Medicare and Medicaid. And then in the 2000s, mid-2000s, we expanded the drug benefit, Medicare Part D, and George Bush signed that into law. That is our healthcare policy framework in this country. We built up to this, and we continue to see uninsured persons in our society, and we kept adding new pieces of the puzzle, and that brought us to 2010, and you saw, and you have still witnessed, many years, 8 years now, of fighting about the Affordable Care Act since that time. This country is very much in disagreement about what our health framework should be, but I wanted you to see that it was never designed as a unified structure. It was designed in pieces. We had a fairly short-term solution to a short-term problem, and we've had accretion over the years. Now we have, over the decades, now we have a disjointed system that is not exactly what we want it to be. And Sam used the term this morning that is often used to describe our system as a broken healthcare system. I want to suggest to you that there's another way to think about it, and that is it's not broken at all. And here's what I mean. This healthcare system was built to recruit workers in the era of wage controls. It was built to cover retirees until the end of their lives, built to cover uninsured people in America, and built to treat people in the emergency room. That's what it was built to do, and it's doing that quite well. This is the conclusion I would lead you to. It was not built to do the things we wish it would do, like encourage healthy behaviors, manage chronic disease, and control cost. When we say it's broken, these are the things we wish it did, but we have to reflect on the fact that it's not what we built it to do. And so my conclusion for you is the problem is not that it's broken. The problem is it's doing exactly what it was built to do, and that's to address acute illness regardless of cost. And that's not what we want it to do anymore. So the fact that it's not broken is precisely why it needs to be changed. I'm not making a case that it needs to stay the way it is. I just think we should all understand that it is doing what it was built to do. So with that, I want to turn to these guys and ask, so where do we go from here? And John, I want to ask you first, right out of the gate. You mentioned Prisma Health, and Greenville Health System and Palmetto Health, two of our state's largest systems, have come together. Why did you do that, and how does that relate to what I've just framed up?
Well, I would say to the group here, I've heard Thornton do this presentation several times. I think it's fascinating. He stood up in front of a huge group of our health system leaders in the state and pretty much delivered the same message that the system's not broken. It's designed to accomplish the results that we have today. It is completely the opposite of where we think it needs to go. And so I thank you for framing it up in 10 minutes like that. And I'll answer the question that you mentioned about Prisma Health. Why did we take two of the largest health systems in the state and make a decision a year ago that we wanted to integrate and align? But before I do that, I want to add a couple comments to what Thornton just mentioned. And so in the middle of the lives that the three of us here live on a daily basis, coming into our respective healthcare systems, we get the opportunity to hear unbelievable stories about what our team members that work under the umbrellas of our respective organizations do. And so there's not a day that goes by that I don't get the chills with a story of a miracle or a success or a car wreck and how our team came together to save somebody's life, or a stroke, you name it. When you walk through the NICUs and you see the little babies that fit in the palm of your hand, and somehow 3 months later they come out of the other end of the NICU and they turn out to be productive members of society, it's amazing to watch them go through their journey in life. And there's some statistics that I think are important to add to what Thornton just mentioned, just a few facts that I want to lay into it that led Prisma Health to ultimately determine or Palmetto Health in Greenville, that we needed to come together as one organization. So think about the forces that we're facing on a daily basis. They're known to many people, but demographic changes. Until next year, the largest generation in the history of the United States, the baby boomers, they're entering the years where they're going to need most of their health care. 3 million per year retire and they qualify for Medicare. When they qualify for Medicare, we get paid about a third of what we do if they had employer-sponsored health insurance, and they're coming into a system in a massive way. Next year, in 2019, actually, the millennials passed them in terms of the numbers, but it's still huge. 75 million people will be transitioning into Medicare. So there's demographic changes that we feel. All kinds of conversations about outcomes. Access. Well, who gets access? Well, if you have a commercially insured card or you're employer-sponsored, you have a different path in. If you're unfunded or you're Medicaid, all three of the organizations up here, forever, at least in our organization, 126 years, we existed to take care of all people regardless of their circumstance in life. And so it doesn't matter where you came from, we're going to take care of you in our organizations. That puts pressure on us as not-for-profit health systems, but quality, access, and cost is what's the big national debate. The financial realities, so the American healthcare system globally spends about $3.6 trillion a year in healthcare. And if you think about that, it's $10,000 per American. Think about the average wage. So in a family of four, $40,000 a year for healthcare coverage. Your employers are picking up a lot of that. Employees are picking up more. We talk about the hot potato. But now the hot potato is landing into the hands of people with high deductible plans where more out-of-pocket cost is coming from them, and so they're shopping. So the notion of consumerism, where can I get in at a lower price point, better access, is affecting the industry in a major way, and it's having a huge dynamic. It's just a reality that we're facing as well. I had a CEO or a owner of a car dealership ask me recently, he's like, why are your costs going up so high? My costs are going up 10% a year. I can't afford the increase. And I said, well, let me just describe it to you and use an analogy. It may not be the best one, but I'll just say it quickly. We have 92 different payers that pay Palmetto Health to take care of about 1 million people a year. And it's all the way down to you could come in, have a heart attack, stay 3 days and leave, and we get paid $0 if you have no insurance and you're not able to pay. Or on the high end that we get paid is about 60 cents for every dollar that we charge. But if you think about Palmetto Health and these crazy bills that go out the door, Medicare pays us about 15 cents on the dollar. Medicaid pays us about 19 cents on the dollar. The state health plan, being in a capital city, which is most of our employees, pays us about 30 cents on the dollar. And then all the commercial carriers pay us somewhere around 60 cents on the dollar. So I said to this guy, imagine if 92 different people pulled into your car parking lot at your car dealership and you had no idea what their funding source was. This is the daily life of us living in health systems. You have no idea how many Medicare, Medicaid, unfunded, commercially insured, but 92 of them are going to drive off your lot with whatever car they came on there to get. And you might get 15 cents of your MSRP, or you might get at the maximum 60%. And at the end of all that, you better have analytical systems in there that can predict, can you break even or make a small profit or not? And he said, that's absolutely crazy. And I said, that's how we get paid. I have zero competition for unfunded patients. Zero. We have all the competition in the world for the 1 out of 5 patients who pays us more than our cost. And that's generally employer-sponsored or the commercially insured population. And so that's just the crazy dynamic, as Thornton painted the picture of how did this system get to where it is today. Most of our system is designed around a payer model that is completely almost impossible to predict, but it's the shifting of the dollars back and forth to try and break even and make a little bit of money and then reinvest it back into our systems. Workforce, I'll just mention this, and then I'll stop by mentioning something about Prisma Health. So we're projected to have about 200,000 doctors. We're going to be short by 2025, which is right around the corner. A report came out nationally last week that said South Carolina is predicted to have the 4th worst nursing shortage in America. In our health system last year, we spent $60 million on outside temporary labor that we had to bring in because we don't have enough labor in the state to meet the needs that we have in Columbia, South Carolina. $60 million, stunning number. We pay them almost twice as much as we'd pay a full-time person on our own staff. So there's huge opportunities for us to have a workforce and a pipeline. I understand that was discussed earlier, but these are dynamics that we're facing. And so over about 2 or 3 years ago, we got into a position of saying, how big do we need to be from a scale perspective to build the infrastructure to be able to partner with the appropriate partners and truly improve the health of the population, transition from a sick care system to truly a value-based healthcare system. That is not what we are today, but how big do you think you need to be? And there's the national debate of how many billions do you think you need to have the infrastructure in place? Well, we made a decision that the value system between Greenville Health System and Palmetto Health was completely aligned. We both have USC schools of medicine on our respective campuses. We have partnerships with other major universities, Clemson, you name it, throughout the state, our technical colleges, that we felt by coming together in one state, it was going to best position us to begin to make this transition from a sick care system to truly improving the health. I didn't mention this, but I would say the leading number that our board continued to talk about is South Carolina ranks 44th in America in our health outcomes. In a country that ranks dead last of the 11 wealthiest countries in the world on health outcomes. The most costly place on the planet to get health care. And the United States ranks last, and in South Carolina, we rank 44th of the states in the United States of America. And our goal, the governing body's number one goal, is to improve health outcomes in the state of South Carolina. That's why we came together. We're going to celebrate our 1-year anniversary next month, and it has been a crazy year, to say the least, as we're trying to take cost out and rationalize the revenues coming in the door with expenses that are going up faster than the dollars coming in. That's the challenge that we're faced with, and I look forward to talking more about that in a little bit.
So I'm going to skip Dr. Springhart because you guys are part of the same system now, Prisma. But I want to ask Pat, surely you have the same kind of strategic conversations going on at MUSC.
Yeah, I mean, every single health system, every single hospital in the United States is going through this right now. So there are 6,000 hospitals, several hundred health systems. Everybody is going through this. And, the challenge of the next 5 years is care transformation. I mean, we deliver care today the way care was delivered in the 1940s. It's very physician-centric, very nurse-centric, but think about what's happened since the 1940s or 50s. There's been 70,000 different diseases discovered since then that we can now treat, 4,000 additional procedures that didn't exist in the 1940s. And so we got to figure out how to pull all this together. There's more data than we've ever had. And so all this stuff is coming together, and we have to care transform because what everybody's looking for, patients, families, payers, other businesses, they're looking for healthcare that's more reliable, that's higher quality, and the biggest thing they're looking for is healthcare that is cheaper. So we got to figure that out. There are different ways of going at that. John mentioned one, scaling up. We're not against scaling up. We're looking at the same thing. We're not a small system. We're the second or third biggest system in the state, so scale is important. But we're also doubling down real hard on innovation, new ways of doing things, human-centered design. We've completely redone our innovation center in the last few years. We have an advantage being a health sciences university that we also do a lot of teaching, so we can begin to incorporate that early. We also do a lot of research, and we can study it directly. But it's a heck of a challenge, and we think we need to change. There are health systems that are saying, we're not going to change. We're going to ride it out. We're going to ride out this volume-based system, and we'll see what happens at the end. We don't think that. We think we need to control our own destiny, and we're betting big on partnerships and innovation.
Great, thanks. I'm going to jump over to Dr. Springhart now. Patrick, you spend, you've described it to us, you spend half your time in clinical practice and half your time in innovation.
That's correct.
So do you want to give us your thoughts on why we need to have the healthcare leadership, the delivery leadership, and the life sciences leadership working more closely together?
Well, I think it goes back to what we've heard all morning long in terms of workforce development. I think to get to your question, I want to make a comment about, I think as Pat was saying, we're trained to be left-sided thinkers. We're very analytical, science, math, logic, and we need to shift that not only in what we're doing in our communities to help with other companies to come here, but also how do we teach clinicians differently, right? So if someone can look at something differently and think about it differently, then you're going to have a different outcome. So one of the things that we've done at the USC Greenville location for the School of Medicine, we have an innovation clerkship where kids are taught economic development by Brian or tech transfer by Cody Reynolds and David Suddeth. We incorporate companies to come in and try to teach physicians to think differently about how to deliver the care. I know MUSC does a lot of telehealth. How do we deliver care differently instead of doing it the traditional way? So I think that is one of the first things that we need to do, is also train our doctors differently and not train them just in the traditional way that we've always trained them.
Great. You want to elaborate on that, or?
Well, I did want to follow up on what
Yeah, go ahead.
both these gentlemen were saying in terms of where we sit from a South Carolina opportunity standpoint, maybe. If we're 44th in the country and 47th for high cholesterol, 47th for low weight infants, 43rd for diabetes, 43rd for smoking, that's abysmal, right? That sounds horrible. But if it was never intended to be that way, but if we just take that and then turn it 180 degrees and look at it differently, what does that mean for a company, a startup company or a company from California, let's say? What do companies need? They need proof of concept, right? And to prove their concepts, they have to have data that's statistically valid. So statistically valid data requires power for those statisticians in the room, right? The way to improve power is to increase your sample size, the number of people that you test, or to have the greatest delta, right? So what do we have the opportunity in South Carolina? We have a great delta that we can use, right? We can only think about going from 44th to 30th rather than from, maybe in California, from 3rd to 2nd. So that's an attractive thing for companies, in my opinion. And I think that that's something we should use together to bring people here to help innovate. Also, if you think about what does that mean to those companies? So if they have to recruit more patients to improve their power, at that point, that costs them money. That's an expense to those companies. And so that will decrease their expenses. This week, we talked about a company that called us about bringing a technology using CRISPR for cancer care. So they need to produce the product close to the administration site, right? So in order to do that, they're going to need a cheaper labor force. They're also going to need to have the folks that we talked about, how to think about the problem differently. And I think it's just a matter of, if they can decrease the amount of people that they need and create the delta, that's the business sell for me for those companies. And I think that's something that we're not exploiting. We keep saying, like, look at how poor we are and look how poor we're doing. Well, that's just opportunity knocking there.
Great. That's really helpful. I'll add for the benefit of the group that our hospital community has been a national leader on several occasions with Atul Gawande and Harvard University to try to improve surgical safety on a statewide scale. We've done it with the Joint Commission, which is our accrediting agency, to try to drive toward high reliability organizations. And that is because we have a collegial community, we have a state that is based on relationships, and that has a population size that's meaningful but not impossible to manage. So we already have confidence in our ability to work together on these kind of projects, and we are very much, I think, open to exploring that in connection with the life sciences industry. So we'll talk more about that after this conference. But let me ask you guys now, what do you see as the biggest challenges for your organization? And I'll come back down here to John and go back down the line. Next few years.
Yeah, I think we touched on some of those. Change management in an organization. We have 30,000 team members that are under the Prisma Health umbrella. We've got 14,000 that are working in the Midlands market. And it still fascinates me, the discrepancy of thought relative to how fast we need to move. And the quote that I am constantly saying and spreading out through the organization is one that Jack Welch made years ago. If the rate of change on the outside is faster than the rate of change on the inside, then the end is near. There is no question the rate of change on the outside, what the marketplace is demanding that we do to deliver a more personalized, coordinated, less costly experience is real. And my biggest fear under the change management and how quickly we can convince and align 30,000 team members to head in a direction that they're not accustomed to going is that we don't move as fast as the market's going to demand. And so we are already, hospitals across the country. Last Tuesday I was in Dallas with 24 health system CEOs for a conference for a day that was moderated by Joe Swedish, who just retired from Anthem, and Dr. Brent James, who used to be at Intermountain Healthcare. And the fascinating thing is they put a chart up from Moody's looking at the operating margins of health systems across the country, the top 120 health systems. In the last 18 months, they've been cut in half, right at half. And so the revenues are going down, and we're not able to get our expenses out faster than the revenue decline. And so from a change management perspective, that can't go on for long. It's happened in Palmetto Health 2 years in a row now. And so our goal is to try and operate the thing at a 2% margin, and we're struggling to make that happen. And so change management is a big one. My second one over the 3 to 5 year window that I would just point out here is we design the health system of the future. The reimbursement system, as you just heard, is not aligned around that. And so how do you design a system, begin to move an organization that's this complex with that many fingers in the pot, if you will, and be able to build the bridge financially to be not just solvent, but to be able to thrive. And so that's going to be a real challenge because it's going to affect money that's going into pockets of certain people today in the $3.6 trillion industry. How do you shift that around to deliver more value to the people that are ultimately paying the bills? If we don't do it quick enough, the examples of the Amazon, Berkshire Hathaways and the JP Morgan Chase or the countless others that we continue to hear, the commercial market's going to move in a different direction, and we're all going to be left with a safety net health system, high fixed cost, at a price point that the commercially insured patients and the employers are no longer going to pay for. And so they're always going to need hospitals, but right now the venture capital money that's being poured into this, no other industry has as much money being pumped into it as healthcare, but they're all going after the people who have money and the ability to create a different experience, lower price point for them to make it happen. We rely on that population, as I described earlier, financially to float the whole system. If they move out and we're left with the other 80% of the population, that in a 3 to 5 year window, how we move from point A to point B, those are the two largest, and then the workforce challenges I already mentioned earlier. We have to have a pipeline. We should have a line of people out our door under the new model that was discussed earlier, thinking differently about how we deliver care instead of the model that we're in today. It's just not sustainable. That's not 5 years out. That's now.
Yeah, thanks, John.
Yes,
Pat?
sir.
You know, I think the challenge is 5 years is not a long time. And if you just let things go, you know, it's been said that if you try to make a change in healthcare, it takes about 17 years. And so we don't have 17 years to wait. So finding those innovations, finding those partnerships, finding those things that could help change things quicker, I think is going to be the biggest challenge of the next 5 years, because we're saying this has to get done. And if it doesn't get done, there are things, John's pointed some other things out. But you know, my entire career we've been talking about the percentage of healthcare toward the GDP. And it is getting to the point that we're starting to have to, education or healthcare, we're really starting to make some, or roads or anything else, we're really starting to make some choices. And so I think that time, that inflection point is here. So how we take that innovation in, how we find it, and how we do things quicker, I think is the challenge. But I would put that on top of a problem that you all may not be aware of in here, but we're experiencing a severe burnout problem amongst our clinicians. So this is not just the doctors, but it's the nurses, it's really anybody who does clinical work. A lot of that has been driven by electronic health records implementation over the last 10 years, and we've buried our clinicians, and we're not using them in the right way. So there's a whole area, you know, as Patrick was pointing out, that's a whole area right there, ripe for innovation. So, you know, we have to change, and we're doing it on top of a burned out clinical group. It's a tough challenge.
I think to build upon what both these gentlemen have said is, and I appreciate you setting the context of how the healthcare came to be. It was all in good intent, right? But we essentially have a tower, a Jenga tower, right? In each of those blocks, we're trying to deconstruct something that we've constructed, and there's a ton of infrastructure around it. But as a healthcare system, as a provider, we can't do it alone. And that goes back to the question that you asked before. It's our healthcare system, not our healthcare system, right? So how do we take those little Jenga blocks out, each of those blocks representing life sciences, physicians, the payers, the insurers, the health systems, obviously patients, families, communities. How do we take those out and be able to put another block in without absolutely allowing the tower to fall? And I think that is the struggle that we have, and that's the opportunity that we have, is just dialogue, and this is the perfect place to do it.
Thanks, Patrick. I can't help but offer my own answer to the question I posed. What are the biggest challenges? As a person who lives in the intersection between healthcare delivery and policy, I'll tell you that my assessment is the biggest challenges that Americans have a kind of a schizophrenic view of what they want out of their healthcare system. I think Americans really want three things when you reduce it to the essence. They want the best care in the world, they want somebody else to pay for it, and they don't want to be told to change their behaviors. And that's what we all want. Nobody's signing up and say, I'll help solve the deficit, send me the bill. Nobody's doing that. We want high quality, we want somebody else to pay for it. Don't tell me what I can eat and drink and whether I can smoke. So it is a fundamental challenge that presents itself on the doorstep of hospitals every day. So next question, then I want to go and open it up to the audience. What do you think are the opportunities that come to mind for greater dialogue, as you just said, Patrick, between the healthcare delivery sector and the life sciences sector? Let me start with you, Patrick.
Well, first thing, just speaking from a pure clinician, I know that even talking to someone in the room last night, I think when it comes to coming to a clinician, we have so much bandwidth. We're dealing with EMRs, things like that. But also, how do we incorporate the ideas that the life sciences come up with into a clinical scenario, right? So oftentimes people come and say, isn't this a great idea? And I'll use a friend of ours that's a cardiologist in Indianapolis. He says, yeah, that's great. We can determine when people are an AFib or A-flutter or they're having VTAC, and it comes to me electronically. That sounds like a great idea, right? But if he's busy seeing patients all day and he's not looking at that part of the chart, he's notified the patients in that, and then when he finally gets around to calling about the patient, oh, they died about 4 hours after that happened, there's a liability there. And so I think with both entrepreneurship, there's risk. With insurance companies, as our keynote speaker talked about earlier, they're not doing it on purpose. There's risk involved, and they have a budget they have to be responsible to. Same thing with clinicians in terms of, let's say, a surgery that we're going to do. There's risk mitigation. There's the risk mitigation for the patient. There's a risk mitigation for the organization. And I think that is part of the opportunity is how do we de-risk it for all of us, or how do we all take a little bit of risk together to actually drive the change that we want?
Pat?
Probably everybody here can come up with 5 things, and we embrace them all. So, there's so much in healthcare that needs just a ton of innovation. At MUSC, we worry about the entire range, from starting at the basic science level. So, of course, anybody here that's on that end, to developing processes which prevent things like Patrick was talking about. At MUSC, we're very interested in telehealth. We've gotten into the telehealth business. If you asked me 5 years ago, I would have thought that the entire nation would be farther down the path on telehealth, but we're not. And there's just a lot of things to learn there. The more you get into it, you discover there's issues about how to deploy it, and there's technical issues, there's process issues. So, think about, we're always in the mode of trying to solve certain things. A big cost item for us right now that we really don't have good control over is pharmaceutical costs. I think everybody here is dealing with this, and we don't know how to control it. And we look at our organizational costs, and we see it come in 10, 15% every year, and we're doing a lot to try to control it, but it's not happening. So, love to understand how to better control pharmaceutical costs. That could be better pharmaceuticals. It could be a better deployment. It could be any number of things. And I would say the final thing is, and I've mentioned this several times, I've thrown the word partnership around. We think deep partnerships with companies is the way to go, because we have to help explain our problems, and we have to work with the company to figure out those solutions. You're going to hear about one of those partnerships coming up with Siemens. That's something very, very different we're excited about it, and I think that may be a way that life sciences and healthcare providers can come together in the future to really try to deliver on this care transformation.
Great. John?
Well, spot on. I agree with what they just said. There's so many opportunities. I think the bandwidth issue that was discussed is real. And so we're putting together a process under Dr. Springart's leadership that is how do you filter all the requests that are coming in to say, we can help you? I bet I get 20 phone calls a week nationally from people that say, well, golly, you're one of the 50 largest health systems now. Would you mind creating an opportunity next Wednesday at noon for me to fly a team in to meet with you? And we've got to come up with an opportunity to say, what are our priorities? What are the big areas that we think we can focus on and move forward? Workforce, I talked about it earlier. It's just a huge issue. And then you talked about pharmaceuticals being a big issue. I'll tell you, it's not just a plug for it, but with Lou sitting right here, what Lou is doing on the generic side at a national level through Nephron is huge. And actually, we need a lot more Lou Kennedys in this world that are focused on helping us get our prices down on pharmaceuticals. Just our pharmaceutical cost increase on an annual basis outstrips any new revenue. That's before you even consider pay raises, medical device cost increases, IT increases going up. Just our pharmaceutical costs going up about just under 7% a year. It's just not sustainable, and it'd be going up higher if it wasn't for the work that Lou and others are doing in the generic space. We've got to spend more time doing that. And so productivity is just a broader issue because we talk about this all the time. The market wants us to do more for less. That means your entire system has to change. We described that earlier. Predictive modeling, I'll use one example, then I'll stop. We hired a group of graduate assistants to come in from USC. And in 1 week, this group of little technical people came in and they developed a simulation model of our emergency department. And they used queuing theory. And they said, well, imagine this. If you're Google and you logged on and typed into Google, Palmetto Health, internist. If the dial is spun for 12 minutes, how long would you stay on Google as your product for a search engine? Well, when you come into the hospital, you come into the emergency department, the dial spins for hours. We don't know when we're going to be seen, what's going to go on. So they created a simulation model. Our doctors' eyeballs were just stunned. And they said, well, if you got 435 ambulances a day that come in here, you can predict with a high degree of accuracy the types of patients that are coming in your ED every day. It's actually more predictable than the volume of elective surgeries in our operating room, which is the opposite, I think, of what some of us were thinking. That type of thinking of how do you create a model, when do you add a nurse, how do you change your triage protocols, the technology, that's the place where it merged together with a group of students at USC. They were so proud that they gave that to us. It actually changed the model with the way that we operate our emergency departments. That's just a small example, but the ability to bring technology in and use it in simulation and ultimately to get to predictive analytics for us is the opportunities are huge. I will pause and say one last thing. Dr. Brent James said something last week I can't sleep after he talked about it, and you two would know more a lot about this. He said, all right, so $3.6 trillion industry. All the evidence will tell you that between 30 and 50% of what we do to patients does not add value to them. As a matter of fact, it might even harm them. And he said if the national deficit came out a couple weeks ago that we're running a U.S. deficit of $800 billion, and 30 to 50% of what we're doing in the $3.6 trillion industry is not adding value, the deficit for the United States of America is healthcare. So if you want to focus in one place, get your partners picked and go deal with clinical variation in a major way. Because that's the only way. There's not, assume abundance. Assume the money's already in the system. It's just not going to the right place for the appropriate care delivery to get the outcomes. So it's just fascinating. You talk about top priorities, clinical variation, workforce development, and obviously we talked about pharmaceuticals. Those are the ones that we deal with on a daily basis.
That's great. So I want to go to the audience for questions, and we'll open the floor now for that. If you need a question to think about, what could we do differently to help grow the life science industry in our state? Anna, did you have a question? Sure.
This question is actually for Dr. Patrick.
I'll repeat it, Sam. Go ahead, Anna.
My name is Anna Moss. I'm CEO with Moss Medical Institute. And my question is this, that a lot of the medicine has stayed in the past, and there's such a limited opportunity as far as education and when it comes to Eastern medicine combined to Western medicine. I know we talk a lot about the fact of encouraging healthy lifestyle, but also an example with our population in our clinics, most of our practitioners, it's so hard to break them from their old habits of just writing benzos and antidepressants and whatnot, but yet not taking the time to look deep into what might cause those concerns. So for instance, just balancing hormones, vitamin D, in a healthy pathway, not by just throwing a 50,000 IU or whatnot of vitamin D, just natural vitamins and nutrition, we can see a tremendous improvement in their lifestyle. And yet, those are services that are provided out of pocket, and you're kind of holding them responsible for their health, and also encouraging them and engaging them into what's important and what should change in their lifestyle. So as they start to feel better, now they start to eat healthy, they start to practice a healthier lifestyle. So is that a consideration with your school to possibly engage the new practitioners into learning more about that aspect and not focusing just on the prescription or on the traditional path?
Yeah, I would say that in the last several years, we've actually had a big focus on health and wellness. So, up till maybe 5 years ago at MUSC, we were a very traditional academic institution focused on, when you got sick, we focused on getting you well. Health and wellness was not an area that we focused on, and health and wellness in everything. That includes things, just like you said, eating better, exercising better, looking at whether supplements are helpful or not. We have fully embraced. We actually have they're probably more familiar in other organizations called service lines. We have something at MUSC called ICE units, Integrated Centers of Clinical Excellence, and we do have a health and wellness one. So we're focusing on it. We think that's part of the future. As Thornton said, that's not how the healthcare was designed, but health and wellness is a place for us in the future. We're betting on it, and we're looking at it very, very closely.
Thanks. Other questions over here?
Hi, yes. So obviously biotechnology innovation is reliant on commercialization, but the commercialization into your industries are obviously hampered by the cost structures, the very low margins that you have. How do you bring innovative new biotechnology, especially that we're developing in this state, into the industries that you have with these low margins?
Great question, and we talked about this as we prepared, just how many such opportunities hospitals see every day, every week, every month. You guys want to talk about that? How do you incorporate the next technology in a static?
Yeah, so that's a really good question. I struggled early on with that as well, and at GHS and in our Health Sciences Center, we've actually come up with a playbook because folks who are at the seed round have different needs than those who are at their B round. And it's how do you work with those folks? Some need one thing and others need other things. And so we've kind of created a playbook so that we have your barrier to entry is frictionless, right? And it also, like I talked about last night with a local state entrepreneur, sometimes timing is just not the right thing. It's like maybe when I was trying to date my wife. She had a boyfriend and I had to wait, and I waited, and finally she took a date with me, right? It just was the wrong time when I was pursuing her, right? So it may be just the timing issue. So I would say don't give up on the health systems, because there may be something else going on that we need to take care of prior to implementing your product. I can tell you, and I'm sure MUSC is the same way, we're hungry to create change. We want to co-create with you, and we see that as the impact value here.
Pat, you have a comment?
I think we have to get together. I mean, you can't expect, if you got a product that's $500,000 and in this day of tight margins, it's just unrealistic to think you can come in. It's going to happen. We make our investment in things of that size all the time, but the numbers get small. I think the better way for you to come is come work with us, right? We may be able to give you in-kind support for your product. We're very hungry for new innovation. We do things all the time. I can't tell you the number of things that I get across my desk every single week by our clinicians to pay for. I'm sure John gets the same number. And then I just can't fund everything. I think the way to do it is work with us, partner up with us, and we can find a way to do that together. The hardest thing for us to do is when you come in with a single price and then you say, it's $500,000, take it or leave it. That's the easiest thing to say no to. It's harder to say no to a partnership.
John, last comment.
Just
then we're
quickly,
gonna
I would say,
finish.
when you try and run the innovation and transformation model, at the same time you're trying to optimize the current environment, what we found out is that it creates more barriers for the opportunity to think about new partnerships. And so I think one of the opportunities we have under Dr. Springhart's leadership on behalf of Prisma Health is, how do you separate that out and create its own pool of opportunities for us to partner with people that's separate from the routine dollars that we're always fighting over for the traditional way that we operate the system. If they're commingled, it becomes a real challenge. And then my experience with that is we end up losing out on some real opportunities, and we slow down innovation at a time when we actually need to accelerate it. Last week I heard there's a band of health systems across the country that are going in and creating, all of them are going in as big investors to purely partner with innovators in the country that are going to help move the needle quicker on value-based care, separate and distinct from the way that they run their organizations now. It's just big investment pools, proof of concept, take it in pilots, and then scale it across health systems all over the country. That's actually a concept that's worth considering. You invest your dollars in it, and then you have a pipeline of people that say, I want to come help, and that may be a better way too. And so that's something I think we've got to consider.
Great. Okay,
Yes, sir.
I know there are other questions, but we're out of time, so we're going to wrap it up. Join me in giving them a hand for this panel. Thank you.